Look closely at this lung tissue. While rheumatoid arthritis presents clinically as the destruction of joints, its origins are microscopic and extra-articular. The cascade often begins right here, when an external environmental particle makes contact with the respiratory epithelium. Before this encounter can cause systemic harm, a genetic prerequisite must be in place. Patients who develop the disease typically carry specific variations of the human leukocyte antigen genes, known as HLA-DR alleles. These genes lie dormant until provoked by an environmental trigger. Inhaling cigarette smoke introduces toxins that act as a direct catalyst. When the chemical stress of the smoke meets the genetic susceptibility of the HLA-DR alleles, the immune system undergoes a catastrophic loss of tolerance. The body forgets how to distinguish foreign threats from its own native tissue. The systemic collapse that defines rheumatoid arthritis originates in the lungs or mucosal tissues, often appearing years before the first physical ache of joint pain. This diagram illustrates the precise molecular error at the center of the disease, a process called citrullination. Under environmental stress, enzymes alter the structural geometry of the amino acid arginine, converting it into a completely different amino acid, citrulline. Because the native structure of the protein has been permanently altered, it becomes immunogenic. The immune system scans this citrullinated protein and categorizes it as a hostile invader. Local antigen-presenting cells capture this altered peptide and display it on their surface, nestled precisely within the cleft of the HLA-DR molecule. This surface display acts as a biochemical flare. Autoreactive CD4-positive T cells circulating in the bloodstream detect the signal and converge on the tissue. The receptor of the T cell physically locks onto the citrullinated peptide presented by the HLA-DR cleft, confirming the threat. A singular biochemical mismatch in a mucosal membrane provides the spark. The systemic autoimmune cascade is now active. In this flowchart, we trace the consequence of T cell activation. The glowing autoreactive T cell extends a chemical signal, activating a neighboring B cell. The B cell differentiates, manufacturing millions of Y-shaped autoantibodies. These include two specific proteins, rheumatoid factor and anti-citrullinated protein antibodies, or ACPA. RF and ACPA enter systemic circulation, traveling freely through the bloodstream until they reach the highly vascularized synovial tissue lining the joints. Because synovial tissue contains naturally occurring citrullinated proteins, the autoantibodies infiltrate the joint space, physically tagging the healthy native tissue as an enemy target. This tagging effectively paints a bullseye on the synovium, alerting local resident immune cells to begin an immediate attack. The disease has formally relocated. What began as a biochemical error in the lungs is now a localized, targeted siege on the joint capsule. A massive influx of immune cells follows. Dendritic cells, plasma cells, and macrophages cross from the bloodstream into the synovial fluid. Invading macrophages and resident synovial fibroblasts become hyperactivated, rapidly emitting pro-inflammatory proteins, TNF-alpha, IL-1, and IL-6. TNF-alpha acts as the primary catalyst, accelerating local inflammation. IL-1 and IL-6 compound this effect. Releasing all three together ensures maximum cellular distress, recruiting more immune cells and creating a relentless positive feedback loop. The destruction cannot be contained within the joint capsule. Interleukin-6 escapes into systemic circulation, traveling to the liver to trigger the production of acute phase proteins. This systemic inflammation causes collateral damage, driving extra-articular manifestations like the formation of rheumatoid nodules and uncontrolled angiogenesis. The joint has become a self-sustaining bioreactor, mechanically driving its own destruction. The physical manifestation of this inflammation is the pannus. This macro-level view shows a thick, hypertrophic, and highly vascularized fibrous tissue creeping aggressively over the smooth, healthy white cartilage of the joint. Inside the pannus, synovial fibroblasts are proliferating endlessly, thickening the membrane and choking the joint cavity. These fibroblasts release a continuous stream of matrix metalloproteinases and ATAMs5. These specific enzymes act as chemical solvents, actively dissolving the protective cartilage and soft tissue matrix. With the cartilage stripped away, The underlying bone is completely exposed to the inflammatory storm. Activated T cells and synovial cells release rank L particles, locking into receptors of dormant osteoclast precursors and instantly transforming them into active, multinucleated osteoclasts. The osteoclast latches on to the exposed bone matrix, carving deep structural erosions into the bone itself. MCSF is released simultaneously to further stimulate this activation. This is active, irreversible cellular consumption. The bone is being eaten away by the body's own cells. The pathogenic loop is complete. A straight, unbroken line of biochemical signaling connects a citrullonated protein in the lungs directly to an osteoclast devouring bone. Modern biologic therapies function as precision tools designed to intercept the specific nodes of the disease's infrastructure. When conventional disease-modifying anti-rheumatic drugs fail, anti-TNF-alpha biologics, like adalimumab or infliximab, are deployed as first-line precision blockers. We can see the drug hitting the network. The TNF-alpha node turns gray, immediately severing the downstream connections that cause localized inflammation. The efficacy of these TNF inhibitors increases drastically when co-administered with a conventional DMARD, like methotrexate, ensuring multiple nodes are suppressed at once. If TNF blockade is insufficient, IL-6 inhibitors like tocilizumab provide an alternative targeted strike. By neutralizing the IL-6 node, the biologic specifically halts the systemic acute phase feedback loop to the liver. Other biologics, such as abatacept, intervene elsewhere in the map by blocking the co-stimulatory pathways between T cells and antigen-presenting cells. Neutralizing just one specific architect in the cytokine network collapses the entire downstream destructive cascade. For patients who show an inadequate response to downstream cytokine blockers, therapy must shift upstream. Look at the top tier of the network map. A targeted strike element wipes out the B-cell node entirely, causing the subsequent RF and ACPA autoantibody lines to instantly vanish. This is the mechanism of B-cell depletion using rituximab. By eliminating the cellular factories that produce the autoantibodies, the loop is starved of its primary ammunition. Therapies also reach deep into a single cell's internal mechanics. Watch as these microscopic internal mechanisms rapidly freeze in place, halting all movement. This cellular freeze is the work of small molecule inhibitors, specifically JAK-STAT inhibitors like tofacitinib and baricitinib. Instead of hunting down cytokines in the extracellular storm, these drugs bypass the fluid entirely. They jam the aberrant intracellular signaling pathways directly, shutting down the cell's ability to respond to inflammatory signals. Because these interventions are so precise, patients who achieve stability for 12 months or more have a high clinical success rate. Up to 50% can safely undergo a biologic dose reduction while maintaining remission. By identifying the exact molecular intersections of this pathogenic loop, we have gained the ability to systematically dismantle the disease's destructive capacity.